All right, let's just dive right in. Today, we're tackling a massive, absolutely crucial topic in the world of clinical documentation integrity. In this explainer, we're doing a deep dive into the clinical validation of acute respiratory failure, and we're going to align it perfectly with the newly released 2026 AHIMA and ACDIS compliant query standards. Look, navigating the complexities of respiratory documentation is hands down one of the most critical skills you can master. So, let's unpack these guidelines and deconstruct exactly what makes a diagnosis bulletproof.
So picture this scenario, the one we see literally every single day. You're reviewing a chart. The provider has documented acute respiratory failure, but then you take a closer look at the actual clinical picture. The patient is sitting up comfortably, chatting away. Maybe they're on just 1 or 2 liters of a nasal cannula. There's zero documented distress. Absolutely no arterial blood gas derangement, and no escalated respiratory interventions. We really have to ask ourselves, and eventually the provider, is it actually acute respiratory failure, or is it just a case of mild, transient hypoxia that's totally missing the objective foundation for such a severe diagnosis?
To figure that out, here's our roadmap. First, we'll cover the respiratory validation challenge. Then, we'll break down hypoxemic versus hypercapnic failure. Third, we'll map out objective indicators and treatments. Fourth, we'll learn how to structure a compliant query. And finally, we'll look at the impact on DRG and severity of illness.
Section 1. The Respiratory Validation Challenge. Let's look at why this diagnosis is under such a microscope. The reality is, acute respiratory failure is heavily targeted in post-payment RAC audits, risk adjustment reviews, and MSDRG reviews. And honestly, the reason is pretty simple. When a provider documents this condition without rock-solid supporting evidence, things like escalated oxygen therapy, high clinical acuity, or specific ABG findings, it creates a massive compliance red flag for the organization. The diagnosis simply must match the intensity of the patient's presentation and the resources actually being utilized.
The 2026 AHIMA and ACDIS guidelines hit the nail on the head here. They state, clinical validation queries seek to confirm or refute the presence of a documented diagnosis that appears to lack supportive documentation within the record. The biggest takeaway here? Clinical validation is absolutely not about questioning a provider's medical expertise. Not at all. It's about ensuring that the medical record legally and clinically supports the terminology they wrote down.
Section 2. Hypoxemia versus hypercapnic failure. Let's get into the actual clinical criteria.
Let's contrast a completely unsupported presentation with a clinically valid one. Say you have a patient presenting with a normal pH of 7.40, a normal CO2 of 36, a totally relaxed respiratory rate of 12, and slightly low oxygen, like maybe a PO2 of 75 on room air. If that's labeled as acute respiratory failure, you are wide open to a denial. True diagnostic parameters look entirely different. For hypoxemic or type 1 failure, we're looking for a PaO2 less than 60 millimeters of mercury and SpO2 less than 91% on room air or a PF ratio under 300. For hypercapnic or type 2 failure, we'd expect a PaCO2 greater than 50 coupled with acute acidemia, meaning a pH dropping below 7.35.
And distinguishing between acute, chronic, and acute-on-chronic decompensation, well, that relies entirely on tracking these specific vital shifts from the patient's established baseline. Think about it. If a patient with severe COPD lives every single day at an oxygen saturation of 89%, and they hit 88% in the hospital, that might just be their chronic baseline, not a brand new acute failure. We need hard, objective data to prove that acute shift.
Section 3. Objective indicators and treatments. So what kind of physical markers and interventions actually back this diagnosis up?
The clinical evidence creates a very clear dividing line between a supported and unsupported chart. An unsupported presentation often features standard low-flow oxygen, like a 2-liter nasal cannula, with completely normal breathing effort. A validated clinical picture, though, that demands interventions aligned with high acuity. We're talking high-flow nasal cannula, BiPAP, CPAP, or even invasive mechanical ventilation. On top of that, the record needs documented physical distress markers, severe tachypnea, accessory muscle use, altered consciousness, or a major acute oxygen escalation from their baseline.
And when you're pulling these indicators to build your case, the 2026 guidelines demand absolute precision. They state, clinical indicators should include a citation of where they were found within the health record. This means we cannot insert our own subjective interpretations. If the heart rate is 120, you state the heart rate is 120. You do not write tachycardia. The standard requires neutrally extracting the exact objective indicators and noting their specific locations.
Section 4. Structuring a compliant query. We've got the evidence. Now how do we build a compliant query? Building this out involves 3 non-negotiable steps. Number 1, cite your clinical indicators objectively, with exact sources and dates. Number 2, ask a non-leading question. It is strictly forbidden to lead the provider toward a desired financial or quality outcome. And number 3, provide clinically relevant multiple-choice options that genuinely allow the physician to exercise their independent medical judgment.
Now, here's a somewhat surprising fact from the guidelines. Even your query title can trigger a compliance failure. Crazy, right? Naming a template something like Query for Acute Hypoxic Respiratory Failure is explicitly non-compliant because it introduces influencing information before the doctor even reads the clinical facts. The compliant approach has to be visually and textually neutral. Something like CDI provider query respiratory status is perfect.
When you set up the multiple choice answers, you have to give the provider a true choice. Essential options must include diagnosis ruled out, diagnosis confirmed, and usually with a prompt to provide supporting evidence, other explanation of clinical findings, and unable to determine. Having these specific options proves that your query is just seeking clarification, not dictating clinical care.
Also, the rules specifically state you cannot use formatting like bolding, highlighting, or underlining to emphasize a desired response. Whether you're using manual templates or automated, technology-driven EHR nudges, the whole presentation must remain entirely visually neutral. You don't want to inadvertently lead the physician with a brightly highlighted option.
There's a really powerful quote from the guidance I want to share. A query can be considered non-compliant without being leading. Compliance requires that clinical indicators are specific to the patient. This means it's not enough to just avoid leading questions. True compliance means you've actually done the hard work. You've dug into the chart, found the relevant ABGs, the oxygen escalations, the physical exams, and you've presented them cohesively for that specific patient. Section 5. Impact on DRG and SOI. Let's wrap up by looking at why getting this right matters so much.
Accurately classifying acute, chronic, or acute on chronic respiratory failure dictates a patient's CC or MCC status, and that directly reflects the true inpatient resource utilization. It ensures that the severity of illness and risk of mortality scores are captured precisely. From a revenue cycle standpoint, locking in these objective indicators on the front end is basically your ultimate defense against those post-bill RAC audit denials on the back end.
And there is an incredibly important silver lining for providers in these 2026 guidelines. When compliant validation procedures are followed, the guidelines explicitly state, the query response represents the provider's clinical judgment and is not intended to serve as the basis for retroactive claim denial. Doing it right clinically and structurally protects the provider, the documentation team, and honestly, the entire organization.
So I'll leave you with this to think about as you review your next chart. Will your next respiratory failure query survive a rigorous audit, or is it missing that undeniable objective clinical foundation? Focus on the data, stay neutral, and let the clinical indicators tell the true story. Please like, share, subscribe to Decode Healthcare with Harshal.